You see her?
I think so.
Oh, okay. Bobby said she thinks she just saw her log in.
Okay.
So, okay.
I can do the official welcome to the Subcommittee on Access to Care. And then just mention that I want to note that the opinions shared are from the provider's perspectives, and we value and respect input from all stakeholders. Our goal in this subcommittee is to approach this as a collaborative fact-finding mission. So our work is to listen openly. We want to ask thoughtful questions and ensure that all perspectives are considered as we examine all the issues at hand. So thank you all for being here.
All right, with that, we have Kim Clark from the area practice manager from St. Alphonsus. I knew I was going to trip on that medical group. Are you ready?
I am. Good morning. Take two.
Yes.
Well, first of all, thank you for having me. I appreciate the opportunity to speak on behalf of St. Alphonsus and Trinity Health. Happy to talk a little bit about the program, or we can get right into questions.
If you want to share about the program, that would be great too.
Sure, yeah. St. Alphonsus Medical Group Occupational Medicine spans over Idaho and Oregon. From Boise, Idaho to Baker City, Oregon at this point is our geography. We are obviously trying to grow our program, but we've been around since 1979, founded by Dr. Michael Gibson. Bless his heart, he finally, after me begging for years and years, just give me one more year, he finally told me to stuff it and retired a couple years ago. So, but he left us in really good hands. Our current medical director is Dr. Kathy Hughes. She is interim director for Dr. Kristen Slappy, who's been away on military orders now for a couple of years, and hopefully will be back at the beginning of 2026. Our clinics are Boise, Idaho, Nampa, Idaho, Caldwell, Idaho, Fruitland, Idaho, and Baker City, Oregon. So I understand we're focusing on Oregon today, and I'm happy to start questions whenever you guys are.
So you want me to go through the list? Kim, would that be easiest for you?
I'm good with whatever. I can talk off the cuff, or we can go through the questions.
Okay, however you want. You have the list of questions, correct, Kim?
I do. Mm-hmm.
Okay, so why don't you go ahead and
okay, yeah. Our the first question was, how long have you been treating injured workers? And I'm speaking as a cumulative group for the whole provider group as a whole. On average, our group has about 15 years of experience, but many of our providers are longstanding and have greater than 30 years of experience in occupational medicine. Our injury rates vary by clinic, but our average is about 80% of our service line. The other 20% is physicals around employment. The general consensus on the paperwork situation with respect to barriers in treating injured workers, it was pretty varied. Certainly, we acknowledge that the extra admin burden for our support staff is pretty handsome. However, it doesn't necessarily, we didn't see it as a barrier to patient care, rather just more of an admin burden for staff. So I think that was a general consensus around that. As far as insurer being a barrier, again, mixed feelings around that. Some of the providers felt they worked very closely and hand in hand with insurers. And I think it varied based on who the insurance company was, as well as down to the adjuster. But comments ranged from some insurance companies are really great to work with and have great communication back and forth. And then some of the providers felt like they had to chase others and gave examples, but we'll leave that for another time. one thing that was noted by the medical director that would be super helpful from a provider standpoint and would help alleviate some of the barriers is we understand that Oregon, it cannot direct care, or insurance companies cannot direct care, but what would be helpful and prevent a lot of delays in care from a provider's perspective is if the insurance company could offer guidance to the employer when they're signing them up as part of onboarding, if they could say, here's a list of providers. Of course, that doesn't have to be just St. Alphonsus, anybody that provides care in that geographic area, just to offer some guidance to the injured worker and employer when an injury does occur. They just felt that would be helpful and alleviate a little bit of the barrier and hopefully allow for better outcomes. Other providers, I know this varies by health system, but the disconnect that we found within our health system about a decade ago was simply the left hand not talking to the right hand. And how we've alleviated that is twofold. One, our medical director reaches out to other service lines within St. Alphonsus Health System weekly. And then I, as operations, meet every other week with all of the service line managers and directors. And we talk about open cases, our referral system, if there's delayed in appointment turnaround time, with appointment making, unfavorable outcomes, if there's been someone that we have referred to a specialist and they have been referred out from that specialist, that is communicated at that time, and any barriers, and again, unfavorable outcomes around current cases. So it allows for an open. Was there a question?
Yes, I'm sorry, and I didn't mean to interrupt, but we do have a question from the
That's okay.
co-chair, Emily.
Yes, I raised my hand and I realized you can't probably see that on the phone, and I didn't want to interrupt sort of your stream of thought because it was following along and I was taking notes, but I just wanted to ping something. You mentioned that specifically in Oregon that insurers cannot direct care, which we know. Is that different for you in experience in Idaho?
It is. In Idaho, the employer has the right to direct care. And so often when insurance companies are onboarding, they'll partner with health systems like us, and we offer a locations poster that they usually post up in their place of employment to guide their employees. And it gives instructions from, if you're injured, report to your supervisor. They'll instruct you to go to this facility, and typically it's logistically closest to wherever that location is in terms of employer. So it seems to get folks where they need to go a bit quicker, and certainly helps with better outcomes.
Okay, thank you so much. I didn't mean to derail the questions. I appreciate
it. No problem. The other note from the providers is they wanted to touch on insurer versus MCO, and some of the comments stemmed around trying to navigate who needs what information. So the example that was given, or the description was given, at MCO is beneficial at times, and then other times it's just an additional layer for the provider, and I'm sure for others as well. And there needs to be clarity around what information goes to the MCO versus what goes to the insurance company. And I unfortunately don't have a lot or an example to give, but certainly happy to dive into that and circle back with the group if there are examples that are helpful. And then last but not least, around injured workers, there really wasn't a lot of feedback other than providers felt that injured workers could be seen quicker and should have better outcomes if the managed care networks and employers and insurance companies worked a bit more closely in Oregon. So what we tend to see or use as a example in Idaho is a three-legged stool, where everybody is a stakeholder equally, and it just seems there's a better circle of communication. And I don't think we could put our finger on, is it the managed care group that's causing that additional layer? No one could really pinpoint what the barrier is around that, but it was definitely noted that there is a different linkage in Oregon as opposed to Idaho. And the next question was around, do our providers meet to discuss workers' comp issues? And yes, we have lots of communication around that. So we have a monthly group that get together and discuss cases, specifically unique cases or complex cases. And then we have a provider meeting with provider and operations, such as myself, where we discuss cases and, of course, processes and policies and things like such. And then every other week, there is a meeting within the health system at a leadership level to discuss the same policies, processes, continuity of care. And then there's a chart review that's done on a monthly basis, and that is peer-to-peer. So each physician or we call them APPs, typically they're physician's assistants or nurse practitioners in this role, will review each other's medical records. So it's 10 charts a month, and then 15 by the medical director in addition to that, just to and learn from one another, make sure that the continuity of care is there, documentation is appropriate, causation is being addressed, and those sorts of things. And then one other layer of documentation is our APPs are required within our health system to have a supervising physician. And so they have one-on-one meetings monthly as well to discuss cases and performance and all the things that you do as a medical director. So most definitely there is lots of communication that goes on. And then our provider group has a real-time chat daily along with our huddles.
I have another question. I didn't want to do the hand
raise. No problem.
In relation to these monthly and I think you mentioned biweekly meetings that you have within your health system, that spans the different service lines that fall within your health system, are there instances where you are co-treating a injured worker with a service line that does not fall within your health system? And if so, do you extend that discussion to those service lines or providers outside your health system? Or is it really all of this communication is happening under your own St. Alphonsus roof?
Yeah, great question. All of that communication is happening within St. Alphonsus. Any communication or any patients that are sent outside of the network, then that is done peer-to-peer. So our physicians, of course, have private numbers for the physicians that the specialists that they are referring to, and they speak one-on-one about the case. And that's usually prior to referral and ongoing in tandem around restrictions and modifications.
Okay, so the peer-to-peer are really sort of as needed based on an individual, like the individual's complex case, but that doesn't really extend to having more what it sounds like systems and operations conversations around using cases as examples to improve either outcomes or turnaround times for referrals if you're talking about providers who are outside of your medical group.
That is correct, yeah,
okay.
Because we use real patient information.
Okay, thank you.
We don't extend that offer. Yeah, of course. And then the next question was around, do we have staff in the office to help with workers' comp issues? Yes, all of our we call them support staff, are very well versed in workers' comp, have been through the Idaho Workers' Comp Specialist course, and those within Oregon have just been educated around the Oregon law. I don't know if there is a course. I've not investigated that for our folks closer to the border and over in Oregon, but certainly would be happy to get them set up with that should that opportunity arise. I think it's very helpful I've taken the course within Idaho, and to see the whole picture and process and barriers and successes, and as much as I hate to say it, the bad apples, just gives a full, well-rounded picture of the workers' comp system and helps us help patients navigate through that system. And then the next question was, who do we contact if we have workers' compensation issues in Idaho? That is the Idaho Industrial Commission. They have an ombudsman as well as many advisors that help patients through it. And then the other case that we will use them is in the event that an employer is not insured, but they're sending their injured workers in and want to pay for it and just need a bit of education around the importance of having workers' comp insurance, one, to cover their employees, and two, to cover themselves in terms of liability. We usually utilize them for that education process. In Oregon, again, I don't know of any group that offers that fulfills that role. But if you guys do, certainly happy to investigate it on my end. And then lastly, if some or all of our workers' compensation insurance barriers were removed, would we increase and expand or add to the number of injured workers in our practice? Again, this one was a bit mixed on responses. Some of the providers, or most of the providers, said no, workers' comp and employee related services are all we do, so we see what we see. But some of the providers, after a fruitful discussion, felt that patients could be seen quicker, not necessarily that it would increase volumes, but injured workers could be seen quicker and would have better outcomes as a result, and felt that there would just be less overall litigation because the injured workers getting care and, for lack of a better word, having the seed planted that they will get better and they're on the road to recovery, where the provider will get them back to pre-injury status. So they felt that was a big shift in if barriers were removed. And then one other note that really isn't on topic or part of the questions, but the providers felt strongly about discussing, were the number of IMEs in Oregon versus Idaho. This is another area that they felt was a barrier, again, not asked about on the questions, but definitely felt that it was an unnecessary load. So one of the providers said he sees patients in Idaho and in Oregon and felt the IMEs were at least 10 times the amount that he sees compared to the Idaho cases. And he wasn't certain the reasoning behind that, but definitely felt that it was a barrier to treating the patient and getting them from injured to back to pre-injury status. So I just did want to make a note of that. And then, because I always like to end on a positive note, one of the positives for Oregon versus Idaho is the providers noted, and I have experienced this as well, the VOC rehab program in Oregon is such a great resource for injured workers. In fact, we were working with a gentleman Monday who was injured in such a way that he can no longer do the job that he was doing previous to his injury. And VOC Rehab was helping him get his GED so that he could further his education. And just opportunities like that do not necessarily exist in Idaho. There is a VOC Rehab program, but it's certainly not as robust as Oregon's or as accessible to injured workers. So like to end on a positive note, and that's could be, if that could be developed and cloned into other states, that would be awesome, because it's a great resource.
Thank you so much. That was incredibly informative. I was feverishly typing this entire time. I'll ask my other co-chair, Kim, if you have any questions.
Emily, I didn't hear what you just said.
I was just curious if you had any additional questions for Kim.
Might be me.
Can you all hear me?
No, I can't. Okay. Might have been just me. Sorry.
Oh, no, I was just asking if you had any questions. I didn't want to talk over you, so. Okay, not sure. You're on mute.
Sorry. I see a hand up.
Okay, thanks.
Good morning. Thais Lomax with Sedgwick. Hi, Kim. Nice to hear your voice again. It's been a minute. I just had maybe an informational comment in relation to Kim's note about doctor concerns with the number of IMEs done in Oregon on Oregon claims to try and get things clarified, whatever the status may be. My understanding is Idaho does allow utilization review, where nurses and other medical professionals are giving input on whether treatment plans, surgeries that have been requested, that those sorts of things are appropriate under their claims, where in Oregon, we don't have that option. So really our only option is, conversations with the doctor in charge and or get an IME to help us with that, to then have a conversation based on those IME findings with the doctors to try and put the pieces together. I guess, long story short, if Oregon wanted to look at UR options as possibly a concept, might not be a bad idea.
Yeah, thank you for the feedback and input. Certainly helpful information, and I don't know that our providers have taken that into consideration, but yeah, you make a great point. It certainly would be a very helpful model to put in place if it were appropriate.
Co-chair, I have a question.
Yes.
So if an injured worker is hurt in Baker City and you refer them, do you choose Boise or Bend, or does an injured worker prefer that? Because I just wonder, it's quite a trek to Boise or Bend. So how does that work?
Yeah. It really depends on the injury. So we've actually started a couple of our, let me back up. A couple of our physicians are also pilots and own planes. And so we've started a program where we're a satellite clinic in Baker City, where we're going out now one day a month, but looking to expand as the need calls for it. And it really is definitely getting there. So what we're trying to do is, if the injury is not too complex, we will have the patient seen acutely in St. Alphonsus urgent care and or ED if need be, and then they are following up either with Dr. Hughes, Dr. Isaacs when they're out on site, and or we're doing a telemed. Now, if they need to put hands on the patient, that's a different story, and at that time, we're trying to have them only go to Fruitland. But if specialists are involved, I'm sure many of you know it's limited resources in that area of geography. And so they're often bound to either go to Boise and or Bend, or even sometimes Portland, depending on the specialist.
Because I wondered about the delay in care, because it's in healthcare, it's not only injured workers and there's only a limited amount of specialists, so, yes, that was one question that I had. Thank you so much.
Of course.
Well, if there are no more questions, I do really appreciate your thorough rundown of the questions we gave you. Like I said, it was very informative. Very much appreciate your time.
Of course. Happy to be here, and thank you for the opportunity to speak.
Terry, do we have any public comment today?
We do not. I did just want to give a little bit of feedback from the last meeting that we had. Thank you, Kim, again, for your presentation.
Thank you. Have a great afternoon, guys.
Thank you. I did hear back from the MCO specialist here, Stan Fields, about, because we talked about, nurse practitioners, treating beyond the 180 days from Audrey last week, Audrey Duke. And so, Stan had emailed me and, talked about Providence MCO, has been permitted to amend its certified plan to allow NPs and PAs to provide care for the life of workers claim, beyond the 180-day limitation. And then also Ann Klein had, provided information as well. Ann, are you online? Do you want to, is she there? I think she is. Did you want to talk about the email that you sent to the co-chairs, or did you want me to do that?
Oh, I am here and I certainly can.
Okay.
Just go ahead. Sorry, Terry.
Oh, you go ahead, Ann.
All right,
I
we'll
don't-
arm wrestle it. But I just had followed up one of the points of discussion with Audrey Duke on the last meeting was touching on the limitations she had specifically with diagnostics and physical therapy and some delays that she saw there with limitations in the area. And it had left it a little unclear on whether or not that was felt to be an MCO limitation or a community limitation. And so I just wanted to validate for myself, because I understand that our network options are as comprehensive as they can be in the area. And so I went and did a thorough review of trying to search for all of the physical therapy or diagnostic facilities in and around the Coos Bay, North Bend area. And I was only able to find a single sole proprietor physical therapist that was not in network. All others are in network with the MCO. And in order to find a diagnostic facility for MRIs, I had to go all the way down to the very bottom of the Oregon border, where there's a satellite facility associated with a Northern California health system. So it just demonstrates how oftentimes the work comp limitations are really, even though we're looking at it just through that workers' compensation lens, that oftentimes it's driven by a community challenge that other areas of care and insurance coverage are also seeing and facing. We just don't always have it in front of our face. So I just wanted to provide that data set to the co-chairs on that as well.
And may I ask a follow-up question?
Yes, please.
In the digging, which I have not also done, when we're talking about providers that are outside of network, is that inclusive of other health systems as potential providers? So like if Providence facility is out that way, or Kaiser, I'm just using sort of closed health systems. Did you include those as providers that would be available?
Oh, yes.
Okay, I just want to double check.
Yeah.
Thank you so much.
Yeah, you bet.
So co-chairs, we do not have public comment today, unless somebody wants to make a statement.
I'll give a moment for that really awkward pause where everybody looks around at each other to see if anybody has anything to say before we move on. Okay, that's enough of that. Well, I actually, quite enjoy being able to give people time back in their day. I do feel that as we move forward to begin to have discussions around policy and recommendations, that these meetings are going to need the full length of time. But as of now, if there isn't anything else, Terry.
So our next meeting is August 22nd. I have asked the surgeon to join us. I do not have confirmation for that, but hopefully I will have that soon.
I wish you the best of luck. Surgeons are really great at their job.
Yes.
So yeah, my experience is surgeons often don't have very much to say in general to the public. So with that, I guess then do I move to adjourn the meeting? There's only 2 co-chairs. No, we just end it.
Just end it.
Okay, well, everyone have a wonderful day. I very much appreciate everybody's time. I have so many notes, even from such a short meeting. Lots to think about, and I'm starting to sense some common themes and some things I think we can really do some great work on when it comes to recommendations, some low-hanging fruit that will improve the care for everyone. So I'm feeling very positive.
Thank you. Happy Friday, everyone.
Have a wonderful day.
Bye.
Your weekend.